Well, good morning, good afternoon, and good evening, depending on where you are in the world time zones. I'm Dr. Fiona Stewart, Chair of the Clinical and Scientific Advisory Committee for the MPS Society, and I would like to invite you all to join us in this presentation about some of the grants we've awarded and the exciting work that has come out of those grants. Before we go any further with the meeting, we do have some really very sad news. One of our members of CSAC very sadly died yesterday, so we woke up here in San Diego to that news. Dr. David Whiteman was an absolute powerhouse in the world of MPS. He graduated from Oxford as a doctor in 1978, having previously done a biochemistry degree. He then went and had a very distinguished career in genetics and pediatrics for over 20 years in many of the major academic units in the United States. In 2005, he decided to move into the pharma industry to help develop new treatments, and he was extremely well known in this world and was involved in many exciting projects, particularly finding treatments for MPS II and other diseases. As well as his research, he also was a massive, passionate advocate for patients with rare disease. And so his loss is a very great loss to us. And, we will be thinking of him very much during this webinar. He had actually planned to join us when I was in touch with him last week. So today what we're going to do is we are going to talk to some of the people who've received grants from us and how their work went and what it means for our patient community. We would ask you not to take screenshots of the slides and also to let you know that this webinar will be available afterwards for you to watch in your own time. So our first person we're going to meet today is Dr. Arya Ajay Kumar, and Professor Derrylyn Hughes is going to introduce her, and she's going to talk about some of the exciting work she's been doing. And she was actually the winner of our Dragon STEM competition that we held at the MPS Matters conference.
Thanks, Fiona. So it's really exciting today to have Arya speaking to us about the work that she's been doing as part of our MPS Society grant. So as Fiona said, she was a poster winner and showed us about improving detection and methods for analysis of glycosaminoglycans for patients. So having scientists working on diagnostic methods and monitoring methods for us is really important to the MPS Society and to CSAC, because that enables us to make earlier diagnosis and to monitor people more carefully and more accurately. So Arya is going to share some slides. She's going to talk to us about the work that she's been doing, and then if there's a little bit of time left, I might ask her one or two questions. Otherwise, we'll be taking questions generally at the end. So please put them in the chat or send them on. So thanks, Arya, over to you.
Thank you, Derrylyn. Hi everyone. My name is Arya and I'm a PhD student supported by the Medical Research Council and the MPS Society. And I'm really glad to be a part of this today. So rather than focusing on the technical details of what my project actually is, I'd like to share the story behind my research, why it exists and why it matters and helps the MPS community. So my PhD project is focused on finding better, earlier and more accurate ways to detect the changes in the glycosaminoglycans in MPS. So before starting my PhD, I worked in a laboratory that studied glycosaminoglycans, or GAGs for short. And what really interested me about glycosaminoglycans is that they are very different in how they behave in the body, unlike DNA or proteins, etc. So that complexity of how GAGs work in the body really captured my curiosity. And through that work, I learned about MPS and how this disrupted glycosaminoglycan breakdown affects children and families. So this is when I decided that I wanted to do my PhD and develop my career in this field. So I then joined the University of Nottingham, where I am trying to improve detection methods of these glycosaminoglycans for mucopolysaccharidosis as a potential screening method using a technique called TOF-SIMS, which we have recently established to look at the different types of glycosaminoglycans. So this project comes from both scientific curiosity and a deep sense of responsibility as a mother myself. So why am I focusing on screening? It's because of how rare MPS is, and it's also because children often get diagnosed when the symptoms appear or if a parent is known to have MPS. But the challenge is that this accumulation and its effects often occur before the symptoms start to show, which calls for the need of an early diagnosis, ideally to start the treatment before the symptoms appear. Another challenge is that some of the same gags accumulate in different MPS types. This means that doctors often need to run multiple tests to kind of piece the full picture together. So this is why finding a sensitive, early and efficient detection method is so crucial. This means currently there are multiple samples that need to be taken, which kind of can be uncomfortable and often painful for the patients. So, and some of these samples actually require some processing, which can also delay the diagnosis. So we urgently need better tools to detect this accumulation early and clearly without multiple sample acquisition or processing that causes delays. So this is where I'm utilizing this instrument known as the TOF-SIMS and optimizing it to look at the gags in urine. So why am I using urine? It is because one, I want it to be minimally invasive, and we are able to look at just 1 microliter of urine because of how sensitive this instrument is. So 1 microliter is smaller than a teardrop. And due to its sensitivity, we can also get the information rapidly without much delay. So 1 urine droplet takes about 30 seconds to a minute to be analyzed. So this means that we could potentially develop this into a screening method that is quicker, gentler, and more accessible, especially important in newborns and young children. So how I've developed this project initially is by looking at urine samples given by Dr. Simon at the Manchester Royal Children's Hospital. And I've looked at 10 MPS urine samples against 10 healthy samples with just 1 microliter drops. Just to reiterate that point again, looked at it through the TOF-SIMS to generate information on, it's kind of like each droplet gives its unique fingerprint. And what was exciting is that just by looking at the information we get, I was able to see that there was a difference that is detected in MPS and the control samples. So when I kind of looked into what these differences are, we were then able to look and identify differences that kind of correspond to each MPS type. So this was really exciting for us, and we wanted to see if it can actually, is it able to capture the complexity of multiple samples. So when we added more samples into it, we got an accuracy of 74%, but that currently is not high enough for newborn screening where precision is critical. So looking at the information we got from the TOF-SIMS data, we were able to identify differences that were spotted in MPS samples. And when we looked further into the differences, we were able to see unique differences found in different MPS types. So this really excited us, and we wanted to see if it can work in more samples. But when we tested it against more samples, we only got an accuracy of 74%. And when it comes to newborn screening, precision is critical. So the next step on developing this project is how can we improve this accuracy? So the first thing that is important to this project is access to more samples so that we can teach the model to kind of look at the differences that we can see in different MPS patients to kind of identify the complexity. And the next thing that we are looking is to build the model further. So this means that we need to get MPS-specific fragments because each MPS type has this unique fragment, and some of these are accessible to be purchased, and also access to look at MPS cells so that we can understand the secretion patterns and how they are being detected in different parts of the body. So together, this would then improve the prediction efficacy of TOF-SIMS and its potential as a screening method. But the challenge is that because of how rare the disease is, such standards and cells are actually very rare and can be really costly. And I think some of the samples that we have shipped out has to be shipped out from America, for instance. So this is where I'm incredibly grateful to actually get support from the MPS community and also from Dr. Simon Jones, who has been a key part of my project as well. So such grants like the one I've got from the Dragon's Den at MPS Matters last year, this allows me to have the freedom to actually access such resources that can improve the prediction accuracy and actually let my project continue in its direction, and also allows me to venture out and get training to use complementary techniques, which I'm doing right now even today, where I'm using another technique to look at how these things can, how to look at the different sulfates on the cells and incorporate it into my project. So what matters deeply to me is that this support that is given to me, I can kind of work on it to develop the project, to give it back to the community. And what I aim to do with this project is to improve the diagnostic capabilities for MPS out there and reduce the diagnostic burden for families and also support the clinicians by helping them to get to the treatment part faster. And I just want to end off by thanking my supervisory team, which have been the backbone of this project, and to the student and staff, because it's not a one-man show when it comes to research. Thank you.
Thanks, Saria. That's really great. And thank you for going through some of the challenges that you have in terms of creating a test and validating it. What sort of things would you need in terms of support now to take a test like that for it to be used more widely for the patient population?
So for the first thing we need is to kind of be able to access resources that actually allow us to look at how complex the MPS actually is, because every patient has differences that we want to identify. And in order to do that, I think the current challenge is getting samples. And the next thing is also accessing such resources that I've been talking about initially because of how rare it is. Having a PhD project, our funding is actually quite limited, and it kind of restricts us to actually gain access to such resources. And grants like this has really helped us develop it further.
That's great to hear, and a good message to everybody really working together to help projects like this with samples as well as resources. Great. Well, thank you so much. Do stick around in case there's questions at the end, and I'm going to hand over to Fiona so we can carry on.
Thank you very much, Aria and Derelyn. I thought that was a great presentation, and I think it's really nice to have someone explain how the laboratory side of things works and how important it is for our patient community. I sometimes think it's the bridesmaids and the forgotten part of our work. And my screen has just gone blank here. No, we're back. So now it's my great pleasure to introduce Dan Bailey and Sarah Gosling from Brunel University, who had done a project to look at Fabry disease and increased moving around and exercise in it. And they worked closely with Professor Derelyn Hughes and her team. I guess if this was a podcast, we would be calling them old friends of the podcast, because they have come and presented to us before, which has always been very helpful. So we're delighted that they're both here. And I'm going to start by asking you both, what made you think about looking at physical activity and sedentary behaviour in the management of patients with Fabry disease?
Yeah, so thanks for having us on. Good to be back and talk again. Sarah, are you happy if I start us off on
Yeah,
that?
absolutely. Sounds good.
Yeah, well, myself and Sarah, we've got backgrounds in physical activity and exercise, so that's our research area. And for myself, I do a lot of research looking at developing and delivering interventions to get people with different long-term conditions moving more to help manage their symptoms and their quality of life. And at Brunel, we have a couple of different departments that quite often work closely together. So I'm based in the Sport, Health and Exercise Sciences department, and so is Professor Louise Manfield, who's also an expert in developing community-based interventions. But Professor Cherry Kilbride, who's another collaborator on our project, is based in the Department of Health Sciences, and she's a physio by background. And we became aware of the MPS Society through a colleague who was suggesting that actually we should look to apply to the MPS Society. They might be quite keen to do some physical activity-based research. And Cherry also works at the Royal Free, London, which is where Professor Derelyn Hughes is based. So we got put in touch that way and just started discussing, what could we do that would really fit the interests of the MPS Society and bring in our expertise around physical activity and sedentary behaviour. And that's really where the project was born out of those discussions. And we applied to the MPS Society for funding for a PhD student for a period of 3 years. And that's where Sarah comes in.
Yeah, thank you, Dan. If you wouldn't mind going to the next slide, that would be great. Thank you. So as Dan mentioned, I have a background in physical activity as well. So just to give you a background of where I started my journey in research. So I did a bachelor's degree in sport and exercise therapy, where my degree and my research focus was based on the effects of specific taping on ankle stability and fear of movement in people with chronic ankle instability. So I really started my journey having a strong interest in sport and exercise. And I then went from my bachelor's into doing a master's in physio, still with the idea of wanting to remain in sport at that point. Throughout my physiotherapy masters, I did my clinical rotations and got my student experience on multiple different wards. So that covered intensive care, it covered musculoskeletal outpatients, neuro wards as well. And my research then was focused on Parkinson's disease. So I got to do a lot of private work within Parkinson's as well. And this is where I really developed my love for working with clinical populations rather than the sport direction, which I previously wanted to take. When I was on my ward placements during that master's program, it was actually my final placement where I was on a hyperacute stroke ward. And that was my very first time coming across a patient with Fabry disease. So that is how I heard about the condition in the first place. I found it so interesting in terms of the symptoms, and also the thing that stuck out to me was how most of the clinicians on the ward, including the consultants, etc., some of them hadn't heard of this condition. So for me, this really highlighted that gap in knowledge and research, not only within that ward, but in terms of physiotherapy and occupational therapy. And it's really an area that I thought these patients really could, have that support from the therapy side of things. Most management obviously is pharmacological at the minute, and we really wanted to develop something that we have that non-pharmacological adjunct to those pharmacy options that the patients have. So that was definitely something I was considering during my placements. And then I always have known I've wanted to do a PhD, was looking at what was about, what my options were, and then I saw the PhD at Brunel, which obviously Dan has provided the background to. That was advertised just as I was finishing my master's. So it timed absolutely perfectly for me to then go into helping adults with Fabry disease and providing that physiotherapy provision and seeing what we can do in terms of non-pharmacological options to build on the pharmacological options the patients have. So that has been my PhD. I have been working with Dan, Derelyn on the call, and Cherry and Louise, who Dan also mentioned, and the MPS Society have greatly helped with the funding and the support with recruitment throughout the PhD. So it's involved 3 key studies. I'm sure we have some of the participants on the call here today. So the participants have been super helpful, very keen to be involved, which we're really pleased about. And we've got some really interesting key findings from the project. So study 1 was we were looking at the associations between mental health and quality of life with how active and how much sitting time the individuals did. And we found that lower depression was associated with stepping bouts of more than 5 minutes, That was really interesting for us to find, as well as the fact that increased quality of life scores were associated with a higher daily step count. And we had 100 participants for that study.
Sarah, do you mind if I just add something to those findings? I mean, just to give you a practical take-home message from that, what the findings show is that the more the more often you do stepping for bouts of 5 minutes or more, the lower levels of depression we found in these people with Fabry disease. So you can just do short bouts of stepping, just 5 minutes at a time, but the more of those that you do, then the better for your mental health potentially, which goes alongside the more simpler message around more steps equals better quality of life. It's great to have that finding in this particular group.
Yeah, absolutely. So that really supported us then co-designing the active fab intervention which we've created. So that was with 3 key groups of people. So we had participants who were diagnosed with Fabry disease. We had healthcare professionals from across the UK who specialised in supporting and helping adults with Fabry disease. And then the third group we had was MPS Society staff, and also undiagnosed family members and friends. So we got all of that support system around these individuals, and we asked them in focus groups, interviews, and workshops, how would you like this intervention to look, and what do you think would work? So we found that it would be a 5-component intervention. So an initial consultation with a physio to set and review goals. Those progress consultations are again with that same physiotherapist to keep that same point of contact and have that rapport between the physiotherapist and the participants. We actually developed an educational website specifically for the trial, and that was used quite well initially. And then we had the smartwatch, which is on the right hand side there, the My Smart Band 9. The participants really liked that watch compared to other watches we showed, and there was an optional peer support group as well. We then tested that in a 3-month study. We had 30 participants in that intervention group receiving those components, and we had 15 participants in the control group. Initial findings in terms of safety is the trial has been safe, with less than 1 adverse event reported per participant throughout the trial. In terms of recruitment and retention rates, that went really well. So 96% of the participants that enrolled stayed throughout the trial. And we got some really good feedback in some acceptability focus groups we did at the end, where we asked participants, how did you find the intervention, etc. Is there anything that you would like improving or anything you found difficult? They really enjoyed the consultations and the watch. The educational website they used initially, but that sort of trailed off towards the end. So it was a good initial resource. And then the peer support group, about 1/3 of participants engaged with that.
Great. So we've got another slide in a little while we're going to put at the end. But Fiona, did you want to come in with any questions?
Yeah, I think it's been really exciting to see how this work has panned out. And having looked after Fabry patients for many years, because I am so old, it's lovely to have something that people can do themselves. I think it gives you a bit of your own agency back. So I think it's been fantastic. I do think we're going to be getting some questions coming in. I see one has come in already. So I think we will come back to you guys if you can stay on the call at the end. And I think I should probably say we actually liked your work so much in this that you applied to us for another grant to look at this sort of work in patients with MPS. And so we're very excited about that work, and we will probably get you back yet again. You can have a regular spot on our webinars. But I think it's really good to see it, and it's really good to see that something's quite simple can actually really make such a huge difference to patients. And it's lovely to see your enthusiasm coming through, and it's great to kind of have you guys in the MPS and Fabry family. So I think I just want to say a big thank you to you, but I think we will have questions for you a little bit later, if that's okay.
Yeah, great. Thanks very much. And just say the QR code up there at the moment, that's for a webinar that we're going to put on to talk just a lot more about the research we've been doing so people can find out a lot more and what we plan to do moving forward with that work.
Brilliant. Well, I, for one, will definitely be joining. And can I thank you both? And I'm going to hand over now to Professor Derrylyn Hughes, who's going to introduce Dr. David Marina Martinez.
Thank you, Fiona. So our next talk this evening is Dr. David Marina Martinez, who was a PhD student with us at UCL in the Royal Free, and is now a consultant in Cambridge. And he's going to talk to us about his PhD work on stroke in Fabry disease. David.
Right. So hello everybody, and thank you very much, Darren, for the kind introduction. So it's my pleasure to be here to speak about the research project named Causes, Prevention and Treatment of Stroke in Fabry disease. And lysosomal diseases that are the ones that stem from problems and issues within the lysosome, these little organelles that like the recycled plants within the cells, have been always my main focus of interest, and that's also true for my clinical practice back in Barcelona. That's where I'm from, where my funny accent comes from. So I was a consultant in the Spanish NHS looking after these patients there back in Barcelona. But as the healthcare system is not so well organized, my boss thought, David, you have to go to London and learn from real experts. And that's how I landed at the Royal Free and met Professor Vera Hughes. And for 2 months, I was with the team there. And that's where all the ideas and discussions about this project started back in 2019. And within lysosomal diseases, my main interest lies within Fabry disease, which you can sometimes read about it like Anderson Fabry disease. And this is because it was described in the late 19th century by 2 physicians almost at the same time. And one of them is this is William Anderson, who is depicted at the top, who used to work at St. Thomas's Hospital at that time. He was a surgeon, but nowadays we refer mainly as Fabry disease, as Dr. Johannes Fabry at the bottom worked for a long period of time in Fabry disease. So Fabry disease, lysosomal disease, of course, has a lot of symptoms in patients, but not all patients develop the same kind of symptoms. There are patients that only have heart issues, there are patients that have heart issues, kidney issues, problems in the skin, and the ones that I want to focus on are the neurological manifestations, the ones that are focused within the brain, and more specifically about stroke. And this is because, as you will see in this study, that it's quite an old study published almost 10 years ago, you can see here how patients with Fabry disease, the ones in black, have a higher incidence of stroke. That means that they have more strokes than the general population in the United States. And this is true for all ages, and we know that this is also true worldwide. So we thought, well, if we could identify risk factors that different patients have that predispose them to have stroke, we could try to modify them and prevent the stroke from happening in the first instance, as we do in medicine with other complications such as heart disease. We know that people who have diabetes may have more tendency to have heart problems, so we treat the diabetes and then we can prevent the heart problem. So that was one of our ideas about stroke in Fabry disease. We also know that the immune system plays a big role in the etiology and why the symptoms in Fabry disease happen. So we thought, well, maybe these strokes are a bit more special. Maybe the immune system is involved in them. And this is one of the hypotheses that we also wanted to address with this research. And the third hypothesis was, well, maybe it's not just the blood vessels, maybe the cells, the brain cells like the neurons or other cells are also involved in the mechanisms behind the stroke. So we wanted to assess this as well. So you can see here how the project was and is quite ambitious. And I didn't realize at that time, but these kind of projects and all research requires a lot of time and a lot of money. And as I explained earlier, I was just a consultant in the Spanish NHS. So if I required time, that meant that I had to move here to London and, just do research. But for that, I also needed money, and I also needed money for myself, but also for the research and the project. So I learned that there was a grant call in London in mid-2019. So I flew to London, and it was a grant application submitted to the Royal Free Charity. And I thought, well, because it's the Royal Free, I'm sure that I'm going to get it. So everything will be sorted. But sadly, I didn't get it. So that meant that I had to flew back to Barcelona. And it wasn't the best time because then time went by and then COVID came. So I thought, oh, well, I'm going to be stuck here and, this research will never come alive. Luckily for me, there was another grant call, this time by a Spanish foundation from a bank. It's called the Crescent Foundation, and they wanted to fund postgraduate studies in Europe, and that included as well the UK. And I thought that the story was going to be repeated, but to my surprise, it was granted. That meant that I could come to London, and that's what happened in September 2020, before just the long lockdown that happened just a few months later. And these are photos from that time, and you can see this on the left-hand side is my first day in UCL when I got my ID card, and then on the right side, where you can see the first time that I stepped into the Royal Free after being here for those initial 2 months. And you can see that these photos are real from that time, because you can see the quantity of hair that I got there. So there's a big difference. Right. So I started my research at the Royal Free under the supervision of Professor Hughes. But another thing that I learned is that money is spent quite rapidly in research. Things cost a lot. So we needed to look for further funds if we wanted to do, especially the most technical parts of the research, like working with neurons and cells that are very special and require a lot of expensive products such as cell culture medium. That meant that we had to apply again to several kind of grants, and there was one advertised by the British Medical Association that was specific about neurological conditions. I thought, well, rare diseases, neurological condition, I'm sure that we will get this one and the research will be able to continue. But sadly, that wasn't the case. And I thought that we were going to have real difficulties to finish the research, because it was very difficult to find anybody keen on funding this kind of research. But luckily, we applied for a grant of the MPS Society, and that was granted, and that allowed the research to continue, especially those kind of more technical parts that require quite a lot of money. So what did the MPS Society help us to achieve? Well, I think that we have done quite a lot of things, and although there's more things to be done, I'm really grateful for the support that the MPS Society has provided us. And this is, for example, one paper that we published just a few months ago, where we identified a few risk factors that may predispose some Fabry patients to have a stroke. And we identified this just in a big cohort of patients at the Royal Free. This needs some validation, but definitely the idea is that we would try to get these risk factors, such as, for example, a specific genetic variants, having a concomitant autoimmune disease, several things that may predispose to or protect against a stroke, in order to build a model and then be able to predict the stroke. You can see here that our work with immune cells has shown that these immune cells are more sticky. And this is what we can see here on this graph on the left-hand side. For example, we can see that Fabry disease have monocytes that are more sticky to the blood vessels, and we think that this may be related to stroke. And then we also analyze these neurons, and you can see here that we analyze several things. One, and the last thing that I want to show you is that we analyze how they work. And we know that neurons, they fire electricity, and that's triggered by calcium. And we can see here, and on the right-hand side, there's a video about how these neurons fire. And these are neurons derived from a Fabry disease patient. And they do this in a delay kind of sequence in comparison to healthy ones. So we know there's some abnormalities within the brain as well that may be related with stroke, although we don't know that. It's just like a building foundation that we know that neurons are not working well. So we are very grateful for all the support. This has allowed us to complete and do this research. This is important not just because it's just building blocks for understanding why stroke happens in Fabry disease. You can see as well how this research can then be presented internationally, and as we're going to do in the upcoming World Congress for lysosomal storage diseases. And this will allow to increase this discussion to an international level, and I'm sure that will trigger further research that will also happen in other centers. So that's the benefit of having this kind of support and being able to do this research. So thank you very much for your attention today.
Thank you, David. That's amazing. Can you tell us a little bit about all the benefits of the work that you've been doing in terms of potential
on
future directions?
Yes. So regarding future directions, I think that our work is focused on two main areas. The first one is just clinical. So it's the question about how we can prevent a stroke. So our idea here is we need to know exactly which patients are at more risk so that we can change that. So we have built a model that needs to be validated, and we hope that other people will try to join us and validate that so that we can apply that to the regular clinical practice that's slightly further down the line. But it's true that just this research has also triggered new discussions, and there are new projects that we are doing in relation to this to see whether, as an international group, several experts, we can try to reach an agreement about, whether we need special treatments to prevent stroke in Fabry disease. So there's an application from a clinical point of view, and then there's another application that it's about research. So if we can give this kind of building blocks of new hypotheses of why this may happen in Fabry disease, that means that although the picture gets a bit more complicated, we get new targets, new ideas of future treatments that can be trial, that can be proposed, and then may benefit in the future patients in order to prevent or treat a stroke in Fabry disease. And I just want to finish saying that everything that we can learn in Fabry disease about the stroke has always the application in the general stroke community, so it may benefit as well the whole general community.
And David, just finally, if from what you've learned about stroke and Fabry disease from the project, and if people were asking, if people with Fabry were asking about stroke and what advice you would give them, is there any advice that you could give people with stroke and Fabry? Maybe it's the same as for anybody in the population, but what would you say to patients?
Yes, so at the moment, our research doesn't change how we approach the prevention of the stroke in Fabry disease. It's the same as the general population. Perhaps we need to have a bit of a more stress on, we need to manage other cardiovascular risk factors. This is important in the general population, perhaps a bit more in Fabry disease. That things like having a balanced, healthy diet, blood pressure, cholesterol, things like that, this needs to be under control. There's nothing that we can recommend different to the general population right now, but that's where this work may change things in the future.
Wonderful, thank you. I'll hand back to Fiona.
Well, thank you very much, David and Derelyn. A really fascinating presentation. And I think it does show to you how difficult it is to get research money. You see that people have great ideas, and then it's quite hard to convince grant-giving bodies that your ideas are worth it, particularly for our rare diseases, and we're often regarded as being a little bit niche. And with that in mind, I'm going to move on to our last presenter of the day, Dr. Johnny Kempf from Manchester. CSAC, we first became aware of Johnny a few years ago when he applied for a grant from us to look at airways and told us that his hobby was doing maths degrees because he found it quite relaxing after a strenuous day on the intensive care unit. And we thought that Johnny was a very unique individual. This was a very, very lucky combination of skills, and we were very happy to award him a grant. So I'm going to ask Johnny to come and talk about this. And what I want to ask you first, Johnny, was how did you get on applying for funding initially when you had these ideas?
Hi, Fiona.
Hi.
Can you see and hear me?
Yes, we can.
Fantastic. Thank you for the introduction, and it's a real pleasure to be here, and thank you to MPS Society. So in terms of my journey, it's been quite different because I had always been interested in big data. I'd done 2 masters in data science and statistics, and my other kind of hobby and interest was rare diseases. So I was quite undecided when it came to training about which path to go. I really like critical care. I really liked anaesthetics, but I also really like pediatrics. And within the common stream within all of those was the complex child with a rare disease. So within my journey as pediatric anaesthesia, you comes quite late within our training. So actually put up with a lot of adult work, and I was doing my time on the intensive care with adult patients. And finally, when I moved into looking towards a PhD, I met two phenomenal individuals who I really want to thank for supporting me in my career, which is Professor Ian Bruce and Professor Simon Jones, both based at Manchester. It's an absolute honour that they've been my PhD supervisors, and they've mentored me throughout my career, and I think, always see them as these kind of enigmatic juggernauts within the area as well. Unfortunately, funding in paediatric anaesthesia is very poor, and then I discovered funding for rare diseases was quite poor. And to look at a rare disease in itself, even though it's individually quite rare, but collectively the rare diseases were quite common, to me felt like a huge disparity, and it's quite unfair that this wasn't being researched. So the approach that Simon and Ian and myself we got together and to look at was to look at, do a analysis and do some preparatory work to prepare for a bigger grant. And that was to look at our Manchester cohort first, and MPS 4 was the disease Ian was looking at, saying it's very interesting. Your interest clinically is airway. You like data, so why don't you combine the two? And I found the first step to that was to really get a grant, and that wasn't until the MPS Society funded me that allowed me to do that initial analysis. And also, I think that grant was pivotal in allowing and almost convincing the NIHR to fund me. So I was the first NIHR in paediatric anaesthesia, and I believe in MPS 4 as well.
That's very helpful. And I remember we gave you the grant, and then you came and presented to us sort of some of your preliminary findings. And actually remembering that day, we were all quite emotional because the findings were so exciting. So I wondered if you'd be able to tell us a little bit about what you found and why it moved us all so much.
Yes, no, absolutely. I'm going to move on to my slides. So I will just get them ready to present. Are you able to see my screen?
Yeah. Yes, we can.
Fantastic. So just very quick acknowledgements. I don't have any financial disclosures, and I wanted to shout out and thank you to my primary supervisor, Ian Bruce, again, Simon Jones, Rob Walker, who's an anaesthetist, and a lot of work with MPS and the MPS Society, Mr. Richard here, and the Salford medical team. So I'm going to talk about MPS and why it was an interest to me from quite early on. If in anaesthetic textbooks, they always talk about the most difficult airway you will face in your career is a child with MPS. Pre-treatments are within the 1s and 2s before bone marrow transplant, and then with the 4s with enzyme therapy. These were extremely difficult cases to deal with. And to me, this was always fascinating because I intercalated and did a biochemistry degree, so I found metabolic diseases quite interesting. But the complex airway was something I was just stricken about. So that's where my journey began in terms of that. Airway disease is ubiquitous across all the MPS, across all 9 of the different types of MPSs you can get. And these children can present a significant difficulty for the anaesthetists. And what's been amazing is how multidisciplinary approach to providing anaesthesia, even if it's as simple as some blood tests and a bone marrow transplant, all the way to major thoracic, major cardiac surgery. There's such an integrated, such an amazing paradigm MPS children present in terms of multidisciplinary teams. These children can have up to 3 to 4 procedures a year. Some of the smaller ones may need a lot of blood tests, for example, an LP. So even for something as simple as that, they will need a general anaesthetic or an MRI. And some of the older children may have, need for spinal correction, orthopedic surgery, ENT surgery, since up to 80% of them can have obstructive sleep apnea and may need their tonsils removing. The incidence of a difficult airway is really high in this group, and they can present quite a challenge, but a fascinating group, and it's very rewarding having spent the last 7 or 8 years working with MPS children. We are now faced with this new landscape with technologies, therapeutics such as ERT, bone marrow transplant, and now gene therapy as well. So we're seeing slightly different children who are presenting a bit later, and it's now being moved towards the adult, where the adults are coming to the pediatric services and saying, well, how did you manage these children? So it's a really interesting area at the moment in terms of airway management. So in terms of, before I approached CSAC, I was in this area. So I'd done some preparatory work. I've published a little bit on my Manchester cohort and decided to do my second maths degree after CCTing. I wanted to really do an amazing job as possible in terms of my PhD, but I didn't want to do a pure methodological PhD, and I didn't want to do a pure clinical PhD. So I wanted to take a bit of time. I'd applied for an NHR doctoral fellowship to support me first time, but they didn't really fund consultants at the time. And I don't think I made a strong enough case about why my project was so important. So I took that year out, did a maths degree, which I started, and then 3 months later, COVID happened. So I was back full time again in clinical work, but I persevered and finished. The MPS Society and the MPS conference I presented in 2019 really kind of spearheaded the second NIHR application, which was awarded a couple of years later. There was a delay due to COVID. This then allowed me to develop links not just within the UK, but internationally as well, and really kind of help mature the area of rare disease informatics and more advanced analytics in terms of looking at data quality and completeness, but also practically how we have consolidated multidisciplinary discussions. And a case example was one of the world's first tracheal resections we did in a child with MPS 4 who had end-stage disease. So my project was based on three kind of areas. The first was to look at what are the prognostic factors. So what factors do we think are predictive? So in statistical technique, if we have hypertension, what do we think will predict hypertension? How do we do that? Is we need a really good data set. So I was very lucky at the time. There's been some excellent work by Biomarin, who had really put in a phenomenal amount of work to create a real world registry called MARS. And this involved really fantastic work by clinical colleagues who were, in their own time, putting a lot of time to enter data to create the MARS registry. And they looked at anthropometrics, demographic, respiratory, genetics, ERT. And I was very lucky because I was just given this data set. And when I started my data journey, it's always very easy to say, well, I didn't collect this, why is this missing? There's a lot of missing data. But actually, in hindsight and in reflection, and this probably shows my maturity as a data scientist, is this was a phenomenal piece of work. It encapsulated, I believe, about 20 to 30 different centres across multiple continents. So it's a phenomenal piece of work to have got MARS. And I felt my role was to first look at the data quality and completeness, and to create a predictive model to see if we can predict which children, despite ERT, still develop the very severe airway disease, in order for us to maybe consider alternative therapies on them early. That may be in the future gene therapy and early airway surgery. So my goal was to create a prognostic model. But like building a house is only as good as a foundation. So a lot of my foundational work was therefore looking at data quality and completeness. This moved me on to, within my journey, was to understand a lot about what Morquio is, how Morquio affects the airway, looking at the global data set, what are the baseline trends, what kind of functional decline happens, and moving to patients as well. So PPIE was really important to me. So even at the CSAC application, I had interaction with parents group, and Ian was very, very keen on this, as was Simon, that I meet with these children, understand their journey. And it was just fascinating. I actually wrote that up as one of my modules of my data science degree, was mapping the patient journey and the data journey. And it was really interesting to speak to them what their frustrations were when they were saying that they would go and see their tertiary clinicians, but they hadn't got letters from their quaternary centre or their local, the highly specialised MPS centre, is what we do in the UK, and then the GP wouldn't have that information either. So that was all really important in that early stages.
So, Johnny, that's really helpful to hear all of that. We are running pretty much out of time, but I'm sure there are going to be lots of questions for you afterwards. So are we right in thinking your big take-home message is that the work you're doing is going to help us identify the people who are going to be at risk of major airways problems so we can intervene earlier before they get into big difficulties?
Yes, that's exactly correct in a nutshell.
Fantastic. So I think we've seen, this is a really amazing piece of work. And I think it's something that the UK should be very proud of, that we really have led the way. We have a big respiratory initiative, which you've been part of, and Ian and Simon Jones, where we are trying to make sure we improve the care of patients with MPS airways and have just a much better management and much more equitable management, because I think that's a very important point you raised. So I think is there any other slide you want to show us, or?
Yes, I'm just moving to my take-home messages.
Oh, brilliant, which I probably just preempted.
So I'm just going to quickly forward the airway imaging. So this was really phenomenal. So in your classical chest X-ray, it's very difficult to see the airway, and the 3D modeling is just allowing us to see the airways in a more complete way. And what have been the system level implications due to the CSAC grant? Well, it's allowing centres like Manchester and Gosh to come together, bringing different expertise to offer an equitable solution to all children. I chair the scientific committee in anaesthesia, and I've also been involved with the Royal College difficult airway framework, and we're modelling this on the excellent work that rare diseases, particularly MPS, has in terms of centralised care, standardised use for airway passports, and the MDT level that goes on, which is never really spoken about, but it's just so phenomenal. It's just such a, it's almost paradigmatic in rare diseases.
Fantastic. Well, that is great to hear. So I think you'll agree with me that we've had 4 incredible presentations. We're going to have some questions. I know that perhaps not everybody will be able to stay to the end of the call. So what I do want to say, I think is a very important message. These projects are funded by the money that CSAC gets to be able to award grants. And that money comes from those of you in families and communities who run marathons, have coffee mornings, all sorts of things. Without your money, this wouldn't be possible. We also have RDRP, which is our wholly owned not-for-profit part of the MPS Society, which will do things like the logistics for clinical trials and all sorts of other things. And the money that they earn comes back into the funds and some of it comes to us for research. So I would really encourage everybody who's done fundraising to keep doing it. Also, anybody who has projects, do think about RDRP, because this is what the outcome is. These projects that you heard today could not have been fully funded without RDRP. So I want to say a really big thank you to all our speakers, also to our fantastic comms team who made all of this happen. Now, we've had some questions coming in online, so I'm just trying to get my question chat up. I know a couple of them in advance, and one of them was, did the MPS Society have any role to play in the gene therapy trial in Manchester, which we would all have seen on the TV? And the answer to that is yes, that RDRP actually have managed the logistics of that, which is a really big job when you are moving people all around the world and supporting families. So we had a very big role in doing that and supporting those families. We have another question, which I think is probably to Johnny. Well, it's to Johnny. What sort of functional decline happens re-airways in Morchio children, and at what ages? I suspect you could talk for hours about that, but if you had a brief comment, that would be super helpful.
Yeah, so generally respiratory and airway disease, about 30% of the global population develop the very severe phenotype where by the age of 8 or 9, the trachea starts changing. So you get multi-level airway obstruction, you get buckling, and essentially these children die early within their second decade of life due to tracheal obstruction and airway disease.
They've asked what's the solution?
So the solution is twofold. It's actually preventing this from happening to start with. So whether that's a high yield ERT much earlier, but we've seen some children, despite ERT at a very young age, develop this severe airway disease. It's prognosticating those that will likely to fail from ERT, and whether they be candidates for things like gene therapy may be a possibility, but that needs investigating. And early tracheal surgery, which we've got, which we published recently and have promising findings for. So Great Ormond Street offer that as a national tracheal service, and they've operated on about 12, 13 children with really good results. There's been really good qualitative and quantitative findings from those children who've had tracheal surgery to address partially the airway disease in Morquio.
Fantastic. Now, we've had a question about funding for patients in an overseas country. We'll liaise with you about that question after this meeting. We've got another question about weight issues with MPS children who are less active due to the condition, difficulties to manage weight control, even with help from the dietitian. So I wonder if that might be one for Sarah and Dan, or Derelyn, or anybody who feels able to jump in.
Yeah. Shall I go?
Go ahead, Dan. Yep.
Yeah, sure. Of course, I mean, weight management ultimately comes down to how many calories are coming in and how many calories are being burnt through an individual. I suppose if with a dietitian support, it will be about trying to control the calorie intake. Obviously, we don't know how effective that is for a particular individual. But if they're able to get calorie restriction, because obviously the energy expenditure is probably not going to be very high for an individual with this condition. So if we can get the energy intake lowered, then hopefully that would help. But alongside that, if we can work out what types of movement and activities an individual can engage in and work on a very personalized, tailored approach, if we can get them just expending small amounts of energy throughout the day, then hopefully that can make a meaningful contribution to potential weight management. So it doesn't have to be, right, I need to be doing exercise. I need to be going out and doing what everyone else does for their weight management. It might be balancing the amount of calories coming in and then trying to just accumulate those small amounts of movement throughout the day to just try to keep that energy being burnt over the day, over the weeks. Don't know if Sarah or Darren, you want to add anything?
I think that's absolutely right. A lot of people now across all of the conditions that we care for are asking us about weight loss medications and weight loss injections, and I think it's probably worth saying that there is no evidence in any of our conditions. So I think it's, if people are interested or asking about those, it's really to follow the medical advice. So we don't know if there are any long-term side effects or how they relate, of course, to our conditions. But having good advice on exercise and diet is really important.
That's great. Thank you. Comms team, do we have any more questions coming in?
We do, Fiona, thank you. I've got a question from Simon for Aria. He says, really nice and exciting work, Aria. So much potential for patients and diagnostics. Fabulous to get actual quantitative values for individual GAG species and with a short runtime. Re-application for screening, do you think you might be able to measure GAGs on urine spotted onto filter paper cards? This would permit screening samples to be sent relatively easily to labs.
Aria?
Yes, thank you. That was a really interesting question. Yes, so that's what our current workflow is going towards, kind of expanding the different preparation methods and the different type of samples we can look at. So we can possibly look at filter papers, but the reason why I preferred using urine samples as they are, it's because we can spin them to remove the contaminants that is in them. So by doing that, we can remove things that kind of interfere with the signals that we get. But that is something quite interesting to look at, and also research is very highly based on collaboration. So I'm also going to put in a request to say that We can look at tissues and different sample methods, and this is where I reach out to clinicians and with fellow researchers like Simon, for instance. If you can give us the samples, I'm happy to have a look at it, see how it goes.
Brilliant. That's a great answer, Aria. Thank you very much.
Thank you. And I've got a question from Sophie for Dan and Sarah. Has program adherence and outcomes been better in those who have taken part in the peer support groups?
Yeah, thank you for the question. So we haven't actually finished statistical analyses on the active PAL data for that study yet, so it'll be interesting to see. But the one thing I would say is the peer support group participants versus those who didn't participate in the peer support group, I wouldn't say, anecdotally from me running the trial, I wouldn't say there'd be any key differences, because the reasons that the participants who didn't take part in that peer support group were mainly due to work commitments or purely wanting to be more independent with the trial. It wasn't really anything to do with compliance, because they were adhering to the other measures and taking part in all the consultations, making use of the smartwatch, etc. So it would be interesting actually if we did do some statistical analyses on those that were in that peer support group versus weren't. But just to give you that anecdotal background, the reasons weren't due to them not being compliant throughout the trial. It was purely just that want to be independent.
Thank you. That's very helpful. Any more?
Yes, another one for Sarah and Dan from Alison. Many Fabry patients with significant cardiac disease report uncertainty and inconsistent advice regarding safe exercise. Are there plans to develop targeted interventions or guidance to support safe physical activity for this group?
Yeah, thank you, Alison, for the question as well. I think this is a really important point because throughout the intervention, there were numerous participants that had reported these cardiac issues to me and expressed their uncertainty about what was safe for them. They'd been given certain things weights that they can lift, that they can't lift, to keep an eye on their heart rate zones, etc. So they'd had a mix of feedback and information given to them. And I think the main thing we learned throughout the intervention trial was that a lot of patients weren't aware of, even just breaking up their sitting time a bit more was beneficial for them to move around, even increasing their daily step count a little bit was having a positive benefit. And I think the idea behind a lot of people thinking, physical activity is solely exercise, we don't have to be going to the gym. It can be those small build-ups of movement and building that strength that way. So we do hope that from the feasibility trial that we can then run a full randomized control trial, and we'd really be looking to obviously have a look at specific markers, so fatigue, pain, VO2 max, things like that. We want to be having a look at physical symptoms, not just the mental health side of things. And I think that's really where we'd get more information about what could be safe, and then work on that and developing guidelines hopefully from that point onwards.
That's great, thank you. Any more questions?
I think every other question's been answered. So no, I think we're there.
Well, brilliant. Well, I would really like to thank everybody. I think it's fantastic that we've got such wonderful young researchers. I hope it encourages people to support us financially to enable that research to continue, because as you've heard, all our researchers have struggled to get money. So I hope that's a good thing. I also hope it encourages people wanting to go into research. We are so lucky to have the quality of researchers that we've seen today in our very small area. So I think I would like to just say thank you to everyone. Thank you also to everyone who joined. And I hope some of you will be able to take part in Dan and Sarah's webinar. And watch this space. We have a call for grants going out. So we have about £100,000 in total to give. So if anybody in research is listening to this and wants to apply, please go ahead and do so. All our applications are very carefully reviewed. We can get external opinions on them just to make sure it's done in as clear and transparent way as possible. So thanks again to the team for making this happen, and thank you all for joining us.
Thank you. It's been a
Thank
pleasure.
you. Thank you,
Thank
Brian.
you.